Well, we're back again, uh, thankfully. And, the one question I always ask when we come back from the break is, did everybody hear not only well, but continuously without lapses? So I need for you to respond by either saying yes, or I guess okay, I got some yeses, and that's all I need to know, because if somebody says no, that means that the problem was on your side. Now, another thing I thought of, usually when I, go and recycle my coffee, as soon as I get there, I thought, you know what? I got to ask him something else. A lot of times when I start doing this, I think, well, is my hair uh, in place? Do I look good? And that's a horrible mistake, because my mentor in pathology many years ago, Dr. Martin Swerdlow, he said something I'll never ever forget. If you ever think of, or you have to give presentations or lectures, probably your number one fear is going to be, how do I look? Well, I got news for you people. It doesn't fucking matter how you look. Okay? The only thing that matters is if you get your point across. So when you finish a presentation, which you will do in medical school and residency and your whole life, never ask yourself, how do I look? Always assess, did my material get through? Okay, let's continue on with our chapter now on cellular adaptations, injury, death. And here's where we left off, talking about death and life and cell death and life. I think that if you wanted to boil it down to two things, you remember when you're a physician, you'll be called to pronounce somebody dead, okay? And sometimes it's not as easy as you think. I've seen people put like mirrors in front of people's mouths to see if there's any condensation, to see if they're breathing very, very subtly that they can't even measure, and they have to listen and feel for pulses and listen to the heart. So I think if you want to boil it down, from a human being pronounced dead to a cell being pronounced dead, you could say irreversible mitochondrial function, because that's delivering the ATP from the oxygen. That would be checking the patient for respiratory motion. And then profound membrane disturbances. Okay, in other words, the membranes don't work and the water leaks in and it doesn't compensate. So that'd be like checking somebody for a pulse. So just like you check respirations and pulse for real patients, you can check myocardial dysfunction. And so once again, it doesn't really matter then what life is, right? Because we know that this is death. When a cell dies, before it dies, we talked about all of these reversible changes, but when they become irreversible, that is death, okay? So now we have a irreversible damage or dead cell. How do you know? Well, if you are doing research, the one way to know, and the earliest way to know if cells are dead, is to look at it under the electron microscope. That's looking at it closely. And it's not very long afterwards. You can look at tissues under the microscope. And remember, almost everything that we see in pathology and histology under a microscope is dead tissue, something that died already. Sometimes it died very, very recently, and most of the things are preserved, so we put it in formalin so nothing, changes or autolyzes, or even after death, the lysosomes will be digesting parts of the cells. And then we look at gross appearances. Okay? So that's how we tell if things are dead or alive. In electron microscopic point of view, you will see blebs within the cell and also damages to the cell membrane. See, there's our nice microvilli over here. But as the cell is dead, these no longer are present. You have blebs within the cell. And then there is a sequence of nuclear changes that corresponds. And I think we could call it PKK. It's a spectrum. And that means pycnosis, karyorhexis, and karyolysis. Now, in pycnosis, the nucleus becomes shrunken. And because the nucleus stains with hematoxylin dyes, as the cell nucleus becomes smaller, it also becomes darker. So in pycnosis, a nucleus becomes smaller and darker. In karyorrhexis, the nucleus starts to fragment. Okay, in karyolysis, nuclear fragments are finally digested. From the light microscopic point of view, here we are examining a myocardium, and you might say, hey, is this myocardium dead or alive? Well, let me ask you a question. These are myocardial fibers. Maybe you remember that from histology, but can I ask you, do you see many nuclei within the fiber? Well, that's because they may be pycnotic, they may be fragmented, or in some cases you don't see nuclei at all. So that's karyolysis, or dissolving of the nucleus. And remember, it's a spectrum. Starts out with pycnosis, karyorrhexis, karyolysis. And once these fibers are dead, sometimes it's easy to recognize microscopically that they are dead, because not only are these fibers dead, but these neutrophils are proving it because they're chewing up the dead tissue. Remember, it's not just bacteria that cause influx of neutrophils, it's also the presence of necrotic tissue, dead cells, okay? Now let's talk about the necrosis brothers. We talked about the seven dwarfs and the usual suspects. So let's talk about the necrosis brothers now. This is more of a classical feature of pathology. There are certain words that are put before the word necrosis, and those words depend on their appearances, either gross or microscopic. These are words that were present 100 years ago, and they're still used widely now in all the textbook. So, liquefactive necrosis is tissue that is liquefied. And maybe it's liquefied because it's in an area where there was not a fibrous framework, and therefore it's all dissolved, okay? The classical, and probably the only place, well, you almost always, well, you hear the word liquefactive necrosis, is referring to brain injury. And that doesn't matter whether it's an infarct or whether it's inflammation or even if it's a tumor. Necrotic brain tissue liquefies. Gangrenous necrosis is almost a redundancy because gangrene means there has been no oxygen because of lack of blood, because damage or infarct of the tissues. They usually refer to gangrenous necrosis when they're talking about toes or feet or arms or even bowel. It's a non-specific response to death response to lack of oxygenation. Sometimes they use word wet gangrene if we're talking about some edema and inflammatory changes that go along with it or have preceded it. And sometimes they're talking about dry gangrene. And you're going to get patients in the hospital that maybe are diabetic, and you look at their toes, and not only are they black, but they're as brittle and dry as coal. Okay, well, that's dry gangrene. And there's always been a big discussion about what comes first, wet or dry. Well, sometimes we've had a lot of debates about that in my classes, but it doesn't matter what comes first. Wet gangrene is necrotic tissue in which there's a lot of edema and perhaps even pus, for example, and fibrin. And dry gangrene is something where there is very little of an acute, watery, inflammatory response. Another type of necrosis is called fibrinoid necrosis, and this is probably the most crazy one of all, because this usually refers to blood vessels that have necrosis in the wall, like you would see with rheumatoid arthritis or perhaps other primary inflammatory diseases of blood vessels. And it's because the wall, which is usually muscle or smooth muscle now is necrotic, and it has stains more like fibrin rather than smooth muscle. Even though both fibrin and smooth muscle stain pink, they're still called fibrinoid necrosis. The word caseous necrosis, queso is the Spanish word for cheese, and the word caseous necrosis is almost always used with respect to the necrosis that you see in tuberculosis granulomas. It's a very important term because if you see granulomas and they are not necrotic, it may be something other than TB. If they are necrotic, they usually use the word caseous. And even though cheese is a gross substance, sometimes that's called caseous necrosis microscopically. Fat necrosis is necrosis due to injury, usually traumatic, of fat tissue. So if you do breast surgery and you've introduced a lot of surgical trauma in there, there will be a characteristic appearance of fat, with giant cells and hemorrhage and cells eating up the injured fat. Now here's also a redundant term, ischemic necrosis. And that's basically necrosis due to lack of blood flow. And remember, a lot of these are lack of blood flow too, like liquefactive. Sometimes you hear the word aseptic necrosis or avascular necrosis, which is pretty much the same thing. Or they'll talk about an organ-specific necrosis, to say splenic necrosis. Or papillary necrosis, which is necrosis of the papilla of the kidney, due to several different reasons. So look, if you wanted to go through the whole list, go to a dictionary called One Look. It's one of my favorite dictionaries. And there's 175 words that precede the word necrosis. But I've given you the 6 or 7 that are the most commonly used in medicine. Here's a brain. Here's a brain that's injured. I think you could tell that just from your own symmetrical feel. And if you look at an injured area of brain, whether it's a stroke, whether it's an abscess, whether it's inflammation, whether it's tumor, it will be more watery. You know why it's watery? Because it's whiter. So there's more fluid between the cells than you see up or down here. That's liquefactive necrosis. Oh, and by the way, if it has more water, it has more H2O. If it has more H2O, the H means protons, by the way. It has more protons. If it has more protons, it has more protons to spin. So in cases of brain edema or liquefactive necrosis, you will see increased MRI signals. Usually this is very, very nonspecific. Almost anything that could injure the brain, even if you can't feel or see or palpate the water, will show up as very bright when they do the T2 weighted images on your MRI scan. And I'll tell you another story too. If you know any famous neuropathologists and they cut brains with knives on an autopsy to look at areas that are watery, sometimes the water can be felt better with your fingers than actually seen. So, that's why neuropathologists wear gloves, because if they are cutting through a brain and it looks normal, they'll still palpate the cut surface and see if it's mushier in any area. Here's caseous necrosis. I think you could recognize this as a lung. There's a major fissure, and you could see kind of more of a spongy consistency here towards the base, but most of the upper lobe is yellowish. And I got news for you. If you cut this with a knife, it would have the consistency of crumbled cheese. Now, tissue doesn't crumble unless it's dead, okay? And the funny thing is even though caseous is a gross term, because when you cut cheese, it's often used microscopically. So if you see these granulomas microscopically, they won't say necrotic granulomas. They usually say caseating granulomas. And it's a very important term clinically and pathologically, and also at surgery, because if you see caseated granulomas, versus non-caseating granulomas, that's usually a differentiation between tuberculosis and non-tuberculous granulomas. So, of course, it doesn't work. There are things we should do like stains and cultures, but that's what the old-fashioned guys did. And the word caseating is still used every day in pathology reports. There's a artery, and look, you don't see nice linear smooth muscle cells. In fact, you don't see any nuclei at all. It's just kind of pink. And guess what? Fibrin kind of stains that pink as well. Although at this stage in your life, you're probably saying, well, damn it, everything in pathology seems to stain pink. Well, this is called fibrinoid necrosis because the wall of the blood vessel is not only necrotic, but it has more of a staining process of fibrin rather than smooth muscle. But we know there's no smooth muscle there because there's no nuclei. Here's a gangrene of a toe. Maybe it's most likely a diabetic, but it could be anybody. It could be a guy that was shot in the leg, you know. Most of the deaths during the Civil War were due to gangrene, simply because they had no way of correcting the injuries surgically. Maybe this toe looks pretty dry, but look at the other toes and the medial aspect. You could tell that it's kind of watery, maybe blisters. That'd be called a wet gangrene. Here's dry gangrenous necrosis. The whole toe is black and firm. Now, I hope you can appreciate the firmness of this because we're only looking at a picture and we're not feeling it. If there was a way I could actually have you feel it, then that would be a great advance in computer science, wouldn't it? Let's talk about other types of injury or necrosis. We know that one of the underlying features of almost all types of cell death is hypoxia, ischemia, lack of oxygen, lack of phosphorylation, lack of ATP. But when you reperfuse an area that's ischemic, like in heart surgery, you would think, oh, that's great. We're going to now get some oxygen in there and everything's going to be going great. But the reperfusion or the introduction of oxygen into a dead or dying area could make things worse rather than better. That's called reperfusion injury. Why? Is because you are not just feeding the injured or perhaps dead tissue, but you are feeding the destructive inflammatory process that is around the dead tissue. And of course, we know about chemical injury. I don't want to say anything more about that because you're going to spend a whole year looking at the chemicals that could injure you, especially the ones that you could write with your own prescription pad. So in an ischemic injury, of course, we have a reversible change. You know, if it persists or gets worse, it gets irreversible or dead. But that particular type of death, which you could see clinically, radiologically, perhaps on MRI, grossly microscopically, is called an infarct. So an infarct is a regional area of dead tissue, not just a cell. It's usually visible even with your naked eye. And we'll be talking a lot about infarcts when we talk about hemodynamic disorders. Okay, we talked about the reperfusion injury. In other words, you're introducing new damage to an area that's already damaged because you are feeding the inflammatory cells, which are chewing up and destroying the tissue, with more oxygen. I almost feel embarrassed to show you this one because, you know, there's a whole bunch of things out there that could injure us: chemicals, insecticides, industrial compounds. We're going to talk about the contents of most of the dumps that are used to store toxic waste. Probably the more likely type of chemical injury are drugs, especially the over-the-counter drugs like Tylenol, like aspirin, and their side effects. And we know that there's a dose relationship there's a threshold below which there's no observable effect, and there's another plateau where no matter how much you give, things can't get worse. We know that free radicals can act as injurious compounds. These free radicals can originate from substances or chemicals within the cells that have been damaged, but they also by themselves can damage tissue as well. And I told you we were going to go back and a little bit more about the chemistry of apoptosis and the mechanisms. We defined classical apoptosis as a process in which normal cells that have reached their age are now replaced, they die. And of course, if they die before their time, you could call that pathologic apoptosis or necrosis. And whether you want to differentiate between the two or whether you realize that's all part of the same spectrum, the one thing you should know for sure is that the changes that you see in pure apoptosis versus pure necrosis are basically the same, and we talked about some of those changes. Now, what are some examples of apoptosis? Well, remember all those cells that you had when you were an embryo? Mesenchyme and all these different cells. Well, they're gone now. What happened to them? Well, they died. They died normally, okay? Some of the cells die when you get older simply because of hormonal aging involution. So your thyroid gland becomes smaller when you get to be old, okay? Sometimes you know that certain areas like the crypts of within your large intestine or your bone marrow even, some of those cells have a very, very short lifespan of perhaps just a few days. Well, they die almost about at the same fast rate as they're produced. In fact, they have to, otherwise they'd accumulate, okay? Did you ever look at a tissue, which we did 2 days ago, in which there are inflammatory cells all over the place? Neutrophils, lymphocytes, macrophages. Well, those things are not there if the tissue heals. Well, those inflammatory cells are cleaned up also by the process of apoptosis. Theoretically, your body, if it has cells which are have antigens which are not recognized by your immune system, or harmful cells, or we'll say alien cells or unrecognized cells, those things should be cleaned up, including tumor cells. Some tumors, and the prognosis and survival of patients with tumors, no matter what kind of immunotherapy you use, whether you introduce T cells or whether you stimulate T cells, they are killed. Tumor, malignant cancer cells also are killed. And if we could figure out how to kill all of them fairly selectively, boy, wouldn't that be great? It means that cancer would be what it probably will be anyway within your lifetime, a chronic controllable disease. Okay, now in pathologic apoptosis, which we can call necrosis, you have toxic effects by your usual suspects. In other words, chemicals, physical, microbiologic pathogens. Perhaps a duct obstruction will interfere with the flow of cellular material, blood cells, or even endocrine or exocrine ducts, would result in increased apoptotic rate. Tumor cells, we talked about. And remember, once again, apoptosis and necrosis is a spectrum, even though the concepts are different. This guy dies because of old age. This guy dies because a truck dropped on his head. He died before his old age. That's one way of looking at the apoptosis necrosis spectrum. In the process of apoptosis, a lot of things are kicked in. But remember, like many other things we'll be talking about, it's a linear sequence. Remember, we said not only is there a decrease in the cell size or shrinkage, especially of the nucleus, which is called pycnosis, where the nucleus becomes darker as it becomes smaller, simply because it's becoming more compressed. In other words, it's darker. We call that hyperchromasia. It becomes smaller. It starts to break up, and then it's dissolved. And I want to make a point here. We've been talking about cellular swelling and injury. And even though cellular swelling and injury is a reversible change, but it could result ultimately in the apoptosis morphology independent of cellular swelling, which may have been present. Generally, the whole cell becomes smaller. We talked about the membrane blebs then being in death. And finally, like the big bug that was eaten by the ants, the substances of the cells are digested, lysosomes and a special other groups of enzymes which are normally present but are activated in the apoptotic processes called capsases. Okay? And here's a cell. Here's a nucleus. The nucleus shrinks. Look at the nuclear material now is darker, and it's starting to fragment. So these are two of the middle stages of apoptosis. Of course, the final stage is the cellular material now is recognized as foreign to the body's macrophages, and they are phagocytized. And the usual cell which performs phagocytosis in the final stage in apoptosis is the macrophage. Even though neutrophils can have a role in chewing up dead cells, the macrophages are the key cells. In fact, when you think about macrophages anywhere in the body, no matter what they do, phagocytosis is always a great role. Look at all those little granules in the phagocytes. Guess what? Those are lysosomes. Look at, they're starting to even digest red blood cells over here. Maybe there's something wrong with the red blood cells. Or maybe there's something wrong with the macrophage and it's starting chewing up his own cells. These are all possibilities in pathology. We talked about the proteins of the cell, whether they're filaments, whether they're enzymes. They are basically broken down by a family called caspases, and it's called that because it is a break. It's a protease which breaks at the cysteine aspartic acid level. Okay, and this is the main group of compounds which are activated in apoptosis. You know, nucleases are part of the process, and phagocytic recognition. Okay, once the phagocytes recognize a cell as being dying or dead, especially dead, it comes in there and starts to remove the garbage. Whoops. And we mentioned the subcellular responses, the lysosomal autodigestin, the whole, you know, lysosomes are nothing more but bags of digestive enzymes, and they're kept as nice little granules within the cell. But when the cell starts to die, it starts digesting everything within the cell. Not only is that present with death, it also can occur after death as well, in a process called autolysis, or digesting of cells. So when a cell is dead, the lysosomes are not dead, and they could continue to digest substances within the cell. A good example of that is if you're doing an autopsy, and the patient, of course, has not been fixed in formalin. Hopefully, you like to autopsy them within 24 hours. But if the body has been around for a couple days or a week, much of the tissue within the body is liquefied. It's been auto-digested, particularly areas like adrenal medulla is probably like the best example, Or another good example would be the pancreas, right? The pancreas liquefies simply because the dead pancreas is now releasing enzymes, which are digesting material around it. There's activation of the smooth endoplasmic reticulum in this process as well, okay? There is mitochondrial swelling. Because why? Because mitochondria are just bags of membranes as well. So as the cell swells, as the membrane of the cell membrane swells, the mitochondrial membranes swell too. Breakdown of the cellular chemical structures like thin filaments like actin, myosin, the microtubules, okay, the keratin, the desmin, all of these compounds that make up the structure of the cells are now breaking down. Okay, now we're going to talk about one of my favorite topics as a form of cellular injury and or death, and that's intracellular accumulations. If you look at the textbook of biochemistry, they'll always tell you there's three kinds of material in your body. There's lipids, fats, and carbohydrates. You know, the same as the stuff that you digest, okay? Lipids could be neutral fat, you know, stearates, glycerol stearates, or you can have cholesterol fat. These are fatty compounds. Often, any proteinaceous material, which is going to stain pink because it doesn't have nuclear material, is going to look glassy, and that would be called hyaline. So when you see something accumulating within the cell that's pink and maybe glassy or maybe even slightly granular, that's called hyaline. And all that means is that it's an accumulation of some type of proteinaceous material. Some people like to use the word hyaline with respect to one particular type of protein that can accumulate called amyloid. But technically, don't remember that. Hyaline is any proteinaceous material that accumulates within a cell. Carbohydrates, well, you can have a whole family of things that do not break down glycogen well, and therefore they could accumulate in the organs where glycogen is the richest, like the heart, like muscle, and like liver. Or you can have pigments, pigmentary material, little tiny dots, crystalline material. If the pigment comes from outside the body, okay, it would be called an exogenous pigment, like smoke particles, like tattoo particles. If pigment comes from material that normally is in the body, but now starts to crystallize or is normally pigmented, like melanin, okay, then that's called an endogenous pigment. And of course, calcium, we said that a dying cell accumulates calcium, but sometimes the calcium can even crystallize as tiny little flecks of blue material. And we're going to see examples of that, okay? Now here's the lipid law. Anything that you see with your eyes in a body, that's yellow, especially if you're doing an autopsy. It's probably rich in fat, or it may be pure fat, okay? Now, if you look at that material microscopically, the fat material, it's not going to be there anymore. Why? Because during the histologic processing, we pass it through xylene, which is a fat-soluble solvent, which washes it out. So you already may know that when you're looking at tissue and you see a big wide open white space and it's not a blood vessel, it could very easily just be fat. That fat could be neutral fat, or it could be cholesterol fat, okay, or anything that's lipid. Here's a liver. You say, well, if the normal weight of a liver is about 1,500 grams, hey, maybe this one is 3,000 grams. Maybe it's twice as big. And if you look at a lot of livers, you would say, well, you know, I've been to the butcher shop. I've done autopsies. I know that livers should be brown. But if you look at the surface of this, or better yet, if you cut it with a knife, not with the CAT scan, not with the magnets, but with a knife. That brown is more brownish yellow. So as you know, the lighter shades of brown look more yellowish. So the more fat that's in the liver, the more it will look towards the yellow end of the yellow-brown spectrum. Now, microscopically, it's real easy because now we have a liver, and I think even if you've only seen a couple livers, you can see at least 50% of the cross-sectional area of this liver is white, washed out, fat, lipid spaces. So here, let me just give you a better example of that. Let's say that rather than this liver being 1,500 grams, which is normal size, let's say it was 3,000 grams, which is twice normal size, and you cut it, and it looks yellow. So let me ask you this. What percentage of this entire liver, if you extracted all the fat, how much would it weigh? Well, you could tell that just from looking at this cross-section. About half of what you see with your eyes is white, and the other half is pink hepatocytes. So this 3,000 gram liver has 1,500 grams of fat. That's like a real quick and easy way to do an estimate of why something is increased in size and what makes it increased in size. Now, we talked about cholesterol as being an obvious fat. I want you to look at some of these tiny cells, like there and there and there and there. Do you see the cells that look like they're kind of big and they have foamy or whitish washed out cytoplasm? That's cholesterol inside of macrophages. Cholesterol inside of macrophages, oh my God, you think that could possibly be from an atherosclerotic artery? Well, you betcha, because that's the most likely place they are. But take a look at these other white spaces, like here and here, in which you see linear white out spaces. You don't see these round spaces here, but you see these linear clefts of fat. Well, that's also cholesterol, and they call it cholesterol clefts. So if you have a cholesterol deposition within a tissue, early stage, probably the only thing you'll see are these little foamy macrophages. But as it gets worse, you have these cholesterol clefts. Finally, pigments. There's two kinds of pigments. Pigments that come from outside your body, and pigments that are either normally or abnormally within your body, but they come from your body. Most of the pigments that come from your body are as black as coal. Why? Because in one case, they are coal. They're anthracosis, little smoke particles. They might be only 1/10 the size of a red cell, but we call them tiny smoke particles. If you live in a city, if you live on a farm, if you're a coal miner, if you're a smoker, or if you're a baby that just took their first breath, you probably have a few anthracotic particles in the macrophages of your lungs. If it gets really bad, the lungs can look really pretty black. And usually the degree of anthracosis that we see in patients does not usually depend so much on how they smoked, but it's where they lived. So a non-smoker in a big, that's a coal miner, is going to have a lot blacker lungs than a heavy smoker, that lives in the middle of New York or whatever. And of course, tattoo pigment is also exogenous pigment, and that looks as black as coal as well, although it's really tattoo pigment. Now, the endogenous pigments, they all look the same. They're not black, but they have kind of a golden, yellowish, refractile appearance, which means by refractile, it means they kind of glitter when you look at them. Now, tattoo pigment doesn't glitter. Coal doesn't glitter. It just looks black. But all of the endogenous pigments of whether it's melanin, you know, even though it's a black stain, is a black pigment, it's microscopically golden refractile pigment. The same is a blood pigment. The degeneration of blood cells produces hemosiderin, and hemosiderin is also a refractile, golden brownish kind of pigment. And so is bile, by the way. And so is the pigment that we're going to learn about later called lipofuscin, what they call aging pigment, which you can see in various organs, particularly in the heart or in the liver, but they all look the same. In other words, when you do an hematoxylin eosin stain of endogenous pigments, whether it's hemosiderin, melanin, lipofuscin, bile, which are the four common ones, by the way, they're going to have that golden refractile appearance. But if you do an H&E stain on a tattoo or somebody's lungs, the macrophages in the lungs, they're going to look as black as coal. Here, let's show you something. Here's a tattoo. Look at, here's epidermis, here's dermis, here's deeper dermis, and look, some of these cells are loaded with dark pigment, and that's tattoo pigment. You know that because look how linear it is, okay? You should not have pigment in your skin, unless, of course, you're a dark person, and that pigment should come from the melanin, not from this black stuff, okay? And by the way, even though you're looking at this and it looks like, oh, there's just a few little cells there that have pigment, the entire skin might look black. This is surprising to most people. But if you take a slice of a tattoo that's very black, you're only going to see possibly just a few little linear streak of cells containing exogenous pigment in the deep dermis. Here's anthracosis. Here's a lung. There's all of these macrophages within the lung, which normally populate the alveolar walls, and they roam around trying to clean up junk. And because they are macrophages, they love to go to the lymph nodes, and they go to the lymph nodes through the lymphatic channels. And the lymphatic channels in the lungs, if you remember from histology, are the richest in the subpleural area. So you can have a lung that looks as black as coal. Maybe this person smoked 10 packs a day, or he was a coal miner. And if you actually cut through it, you'll find that most of that pigmentation is right underneath the pleura, and the parenchyma, or the cut surface of the lung itself, won't be quite as black. Okay, here's some pigments. This looks like it's some kind of space. Could it be maybe a lung or something else? And you could see a lot of macrophages with this golden brownish pigment. These are what we call exogenous pigment. And the most common type of endogenous pigment is in an area where that was injured, or perhaps there's hemorrhage, and then there's breakdown of the hemoglobin, which eventually goes through chemical steps through bilirubin-like compounds, and finally hemosiderin. So these are called hemosiderin macrophages. A person with heart failure who has a lot of congestion of blood in his lung, in his capillaries, those blood cells will basically congest. They'll eventually be broken down. A person with heart failure, chronic heart failure, gives you a sputum sample, you might see a lot of these hemosiderin macrophages. Here are some macrophages within lymph tissue. Now, if you don't know whether this pigment, for example, is bile, or whether it's hemosiderin, or whether it's melanin. And remember, there's a whole bunch of very specific stains that you could do to identify. But if you're looking at a golden pigment in the lungs of a person with heart failure, you're not going to think it's bile, and you're not going to think it's melanin, okay? And if you're looking, however, in the lymph node of a person with a malignant melanoma and you see pigment, you might say, whoa, we better verify that this is a metastasis. And there's a whole bunch of very specific stains like S100 or HMB45. And there's even a whole bunch of new ones since I quit practice. but those are still commonly the most common ones used. 2 more PowerPoints, and then I'll let you go because you've been so good. Calcification. There's 2 kinds of calcification. One of them is called dystrophic. See, you got that word dystrophy again, don't you? Yuck. And then you got something called metastatic. And metastatic has nothing to do with metastatic tumors. So, a dystrophic calcification is calcification in cells or tissue, usually that may have been injured. And as you know, we'll talk about it extensively in the next webinar. Injured area can produce an inflammatory reaction, and then the inflammatory reaction can ultimately end with scarring. And very often, it'll go further than that. It won't just end with fibroblasts and collagen, but it'll actually end with calcified substances, little flecks of calcium. Some can be pretty big. Sometimes tumors can calcify. You know, you get calcification within a wall of an atherosclerotic artery. And then metastatic calcification is the calcification due to hypercalcemia. So if you looked at all of the reasons, the differential diagnosis of why you have increased calcium in your blood or hypercalcemia, like hyperparathyroidism is also the obvious reason. Now, the thing that makes this even most confusing is that sometimes you can even see metastatic calcification with metastatic disease, but it's only if the metastatic disease is producing a hypercalcemia, which it might do, for example, if it's chewing up a lot of bone, right? Last but not least, I'm glad we could finally get into a little philosophical discussion here before I let you go with our last song. We talked a lot about damage and death, and it's very possible you're going to be asked as physicians, why did my grandma die? You know, and you're going to have to go into not just a scientific explanation, but the explanation that a caring physician who also suffers with the patient's family. And you could say basically 2 things. Well, they died because it was their time to die. Or you say, oh, well, they died because they had like a lot of injury or the cells were stressed too much. And that's another overall explanation for why cells or people die. Now, if you're kind of wondering whether one is more likely than the other, surprisingly, the pre-programmed theory is generally much more widely used than just the wear and tear theory. Okay? If a person, runs 10 miles a day, that person's going to probably live longer than the person who doesn't put wear and tear on their body, okay? So, I'm trying not to be too philosophical here, but the reason why cells die is the same reason why the whole organisms die. And although this may sound like the biggest cop-out in the world, when you say pre-programmed, it just means it was their time to die. Okay, we're done. Thanks for coming again today.